Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 210 of our Pharmacotherapy MCQ series, which is a collection of clinical vignettes. And the next question reads, which of the following antimicrobial agents can confound the utility of the serum galactomannan antigen assay among patients with hematologic malignancies or hematopoietic stem cell transplantation? Is it A. hydrocortisone, or B. pantoprazole, or C. piperacillin, tazobactam, or is it D. voriconazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. voriconazole. Galactomannan antigen assays are used as part of the diagnostic workup for invasive aspergillosis. Galactomannan is a polysaccharide moiety within the aspergillus cell wall lying exterior to the cell membrane that is detected by assays. Voriconazole can cause false positive test results by inhibiting fungal ergosterol synthesis through cytochrome P450-mediated lanosterol demethylation. Piperacillin is based on natural compounds derived from the genus Penicillium that have been demonstrated to cross-react with the monoclonal antibody used in galactomannan antigen assays. However, this reaction was primarily seen with branded piperacillin products prior to 2009. Generic and branded preparations used since 2012 are much less likely to interfere with galactomannan antigen assays. Pantoprazole has no effect on serum galactomannan antigen assays. Hydrocortisone has no effect on serum galactomannan antigen assays. Please proceed to the next question. And the next question reads, ZPO, a 67 kg, 34-year-old male patient with acute lymphoblastic leukemia post-chemotherapy is admitted to the medical ICU for evaluation. His pertinent vitals include a body temperature of 40.4 degrees Celsius, a heart rate of 145 beats per minute, a systolic blood pressure of 109 mm of mercury, and oliguria for the past 2 hours. Regarding his allergies, he developed hives and severe bronchospasm during amoxiclav therapy during childhood. Samples for blood and urine cultures have been sent to the lab. The results of a chest X-ray are pending. His pertinent labs include a WBC of 0.2 × 10³ cells per millimeter cubed, hemoglobin of 8.8 grams per deciliter, a platelet count of 41 × 10³ cells per millimeter cubed, a BUN of 22 mg per deciliter, serum creatinine of 1.4 mg per deciliter, a total bilirubin of 0.9 mg per deciliter, and AST of 32 international units per liter, and ALT 39 international units per liter. So my question to you is, which of the antimicrobial regimens listed below would be the most appropriate one in ZPO's clinical scenario? Would it be A. Piperacillin, tazobactam 4.5 grams IV 4 times daily and vancomycin 1 gram IV twice daily? Or B. Imipenem cilastatin 500 mg IV 4 times daily? Or C. Ciprofloxacin 400 mg IV thrice daily and clindamycin 600 mg IV thrice daily? Or would it be D. Cefepime 2 grams IV thrice daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Ciprofloxacin 400 mg IV thrice daily and clindamycin 600 mg IV thrice daily. Beta-lactam antibiotics should be avoided in patients like this one with a history of penicillin allergy characterized by hives and bronchospasm indicating an immediate type hypersensitivity reaction. An anti-pseudomonal cephalosporin or carbapenem usually may be used safely in patients with a penicillin allergy characterized by a minimal reaction, such as a mild rash. However, if an immediate type hypersensitivity reaction, such as hives or bronchospasm, occurred during use of penicillin as in this case, avoidance of beta-lactam antibiotics and carbapenems is warranted. Ciprofloxacin and clindamycin are appropriate alternative choices. Carbapenems should be avoided in patients with a history of penicillin allergy characterized by hives and bronchospasm indicating an immediate type hypersensitivity reaction. Vancomycin is not recommended as a standard part of initial antibiotic therapy for febrile neutropenia in cancer patients, and it should only be added if a catheter-related infection, skin or soft tissue infection, pneumonia, or hemodynamic instability is present. Please proceed to the next question. And the next question reads, TMT, a 69 kg, 46-year-old male patient with acute myelogenous leukemia is beginning induction chemotherapy with cytarabine and daunorubicin today. His medical oncologist initiated him on IV 5% dextrose in water with sodium acetate 150 milliequivalents per liter at 125 milliliters per hour for urinary alkalinization almost 24 hours ago. His pertinent labs include a WBC of 72 × 10³ cells per millimeter cubed, hemoglobin of 9.4 grams per deciliter, a platelet count of 184 × 10³ cells per millimeter cubed, sodium levels of 140 milliequivalents per liter, potassium levels of 4.7 milliequivalents per liter, chloride of 99 milliequivalents per liter, total bicarb of 35 milliequivalents per liter, a BUN 38 of milligram per deciliter, serum creatinine of 1.5 mg per deciliter, uric acid 8.1 mg per deciliter, magnesium of 2.2 mg per deciliter, phosphorus 7.1 mg per deciliter, and ionized calcium of 0.89 millimoles per liter. So my question to you is, which of the following would be the most likely causes of TMT's hypercalcemia? Would it be A. hyperuricemia, or B. hypophosphatemia and metabolic alkalosis, or C. hyperphosphatemia and metabolic alkalosis? Or would it be D. hyperphosphatemia and hypomagnesemia? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. hyperphosphatemia and metabolic alkalosis. Hyperphosphatemia, not hypophosphatemia, causes chelation of phosphorus with calcium, leading to hypercalcemia with the potential for calcium phosphate salt deposition in soft tissues, including the kidney. Hypomagnesemia can reduce the secretion of parathyroid hormone, leading to hypercalcemia. However, this patient is not hypomagnesemic based on his current serum magnesium. This patient has hyperphosphatemia, which causes chelation of phosphorus with calcium, leading to hypercalcemia with the potential for calcium phosphate salt deposition in soft tissues, including the kidney. The administration of sodium acetate, total dose 450 milliequivalents per day, in this 69 per kilogram patient would cause metabolic alkalosis, which decreases ionized calcium levels via increased albumin-calcium avidity, thereby worsening hypercalcemia and possibly precipitating tetany. Additionally, this patient is not hypophosphatemic based on his current serum phosphorus. The administration of sodium acetate, total dose 450 milliequivalents per day, in this 69 kg patient would cause metabolic alkalosis, which decreases ionized calcium levels via increased albumin-calcium avidity, thereby worsening hypercalcemia and possibly precipitating tetany. Hyperuricemia can cause uric acid crystals to precipitate in the renal tubules, leading to microobstruction with a corresponding decrease in the glomerular filtration rate. The use of urinary alkalinization would allow greater solubility of uric acid in the urine, however, it would be at the cost of precipitation of calcium phosphate salts in the renal tubules and soft tissues, potentially worsening kidney failure. The main causes of this patient's hypercalcemia probably are hyperphosphatemia and metabolic alkalosis from sodium acetate administration. Please progress to the next question. And the next question reads, RHP, a 73 kg, 45-year-old male patient with newly diagnosed Hodgkin's lymphoma received dexamethasone 40 mg IV today and was started on IV 0.9% sodium chloride at 125 ml per hour approximately 6 hours ago. His pertinent labs include a sodium of 143 milliequivalents per liter, a potassium of 5.4 milliequivalents per liter, chloride of 108 milliequivalents per liter, total bicarb of 20 milliequivalents per liter, glucose 164 mg per deciliter, a BUN of 31 mg per deciliter, serum creatinine of 1.7 mg per deciliter, uric acid 7.7 mg per deciliter, magnesium of 2.9 mg per deciliter, phosphorus 6.5 mg per deciliter, and ionized calcium of 0.9 millimoles per liter. So my question to you is, which of the following abnormalities in RHP are the most characteristic laboratory findings expected in clinical scenarios like spontaneous or cytotoxic chemotherapy-induced tumor lysis syndrome? Are they A. hyperuricemia, hypomagnesemia, hyperphosphatemia, and metabolic alkalosis? Or B. hyperuricemia, hypomagnesemia, hyperphosphatemia, and metabolic acidosis? Or C. hyperuricemia, hyperkalemia, hyperphosphatemia, and hypercalcemia? Or are they D. hyperuricemia, hyperkalemia, hyperphosphatemia, and hypercalcemia? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. hyperuricemia, hyperkalemia, hyperphosphatemia, and hypercalcemia. Hyperuricemia, hyperkalemia, hyperphosphatemia, and hypercalcemia are the characteristic findings in patients with tumor lysis syndrome. These changes arise from the rapid release of intracellular nucleic acids, potassium, and phosphorus from malignant cells. The hyperphosphatemia results in either asymptomatic or symptomatic hypercalcemia, depending on the severity of hyperphosphatemia. However, hypercalcemia is very unlikely given the severity of hyperphosphatemia. Hypomagnesemia is not a common finding in patients with tumor lysis syndrome. Most patients experience hypomagnesemia from acute kidney injury. Metabolic acidosis sometimes is seen in patients with tumor lysis syndrome as a result of acute kidney injury, but it is not a common characteristic until renal replacement therapy is required. Metabolic alkalosis is rarely seen in patients with tumor lysis syndrome. Tumor lysis syndrome predisposes to acute kidney injury, which may lead to metabolic acidosis, depending on the severity of injury. Please proceed to the next question. And the next question reads, DPA, a 68 kg, 79-year-old Caucasian male patient with newly diagnosed non-Hodgkin's lymphoma is admitted for chemotherapy initiation. His past medical history includes hypertension, baseline blood pressure 1 month earlier in clinic 140 systolic 85 diastolic, coronary artery disease status post 1 vessel coronary artery bypass graft surgery 6 years ago, osteoporosis, and chronic renal insufficiency. His lab test results include a WBC of 9.2 × 10³ cells per millimeter cubed, hemoglobin of 12.6 grams per deciliter, a platelet count of 123 × 10³ cells per millimeter cubed, a sodium of 144 milliequivalents per liter, a potassium of 4.8 milliequivalents per liter, chloride of 100 milliequivalents per liter, total bicarb of 31 milliequivalents per liter, a BUN 41 of milligram per deciliter, serum creatinine 1.9 mg per deciliter, uric acid 9.1 mg per deciliter, magnesium of 2.5 mg per deciliter, phosphorus 4.6 mg per deciliter, and a total calcium of 10.1 mg per deciliter. His pertinent vitals include a heart rate of 112 beats per minute, a blood pressure of 90 systolic 62 diastolic, a body temperature of 37.4 degrees Celsius, and a urine output of 150 milliliters in the last 8 hours. So my question to you is, which of the following characteristics of DPA are risk factors for tumor lysis syndrome post-chemotherapy initiation? Are they A. Caucasian race, hypotension, oliguria, and volume depletion? Or B. Caucasian race, hyperuricemia, and chronic kidney disease? Or C. Hypotension, oliguria, volume depletion, and chronic kidney disease? Or are they D. Hyperuricemia, hypertension, and chronic kidney disease? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Hypotension, oliguria, volume depletion, and chronic kidney disease. Although hyperuricemia and chronic kidney disease are risk factors for tumor lysis syndrome, hypertension is not a risk factor. This patient has hyperuricemia, hypotension, and chronic kidney disease. Risk factors for tumor lysis syndrome include hypotension, oliguria, volume depletion or dehydration, pre-existing hyperuricemia greater than 7.5 mg per deciliter, or gout, acute renal insufficiency, and chronic kidney disease. This patient has hypotension, oliguria, volume depletion, and chronic kidney disease. Caucasian race has not been identified as a risk factor for tumor lysis syndrome, although this patient's hypotension, oliguria, volume depletion, hyperuricemia, and chronic kidney disease are known risk factors. Please proceed to the next question. And the next question reads, which of the metabolic abnormalities listed below would be the most difficult to treat in patients experiencing tumor lysis syndrome? Would it be A. Hyperphosphatemia, or B. Hypernatremia, C. Hyperuricemia, or would it be D. Hyperkalemia? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Hyperphosphatemia. Hyperkalemia in patients with tumor lysis syndrome is the result of an inability of the kidneys to clear massive quantities of potassium released by lysed tumor cells. Hyperkalemia may be exacerbated by acute renal insufficiency induced by precipitation of uric acid or calcium phosphate. Hyperkalemia is often manageable with the use of diuretics. Hyperuricemia in patients with tumor lysis syndrome results from the rapid release and catabolism of intracellular nucleic acids, which are catabolized to hypoxanthine, then xanthine, and finally uric acid by xanthine oxidase. Uric acid crystals may form in the presence of acidic urine within the renal tubules, resulting in acute renal failure. Severe hyperuricemia greater than 7.5 mg per deciliter may be treated with raspiuricase, which provides a substantial reduction in the uric acid level within 4 hours. Hyponatremia is not a common metabolic abnormality in patients with tumor lysis syndrome, and its treatment is not considered difficult. Hyperphosphatemia often occurs in patients with tumor lysis syndrome from the rapid release of intracellular phosphorus from malignant cells, which contain up to 4 times more organic and inorganic phosphorus than normal cells. Hyperphosphatemia is difficult to treat, especially when concomitant hyperuricemia is present. Hyperuricemia can exacerbate acute renal failure through uric acid crystal precipitation, which decreases urinary phosphorus excretion. Renal replacement therapy is often required in severe cases of hyperphosphatemia. Please progress to the next question. And the next question reads, which of the therapeutic interventions listed below reduces mortality in patients with acute upper gastrointestinal (GI) bleeding according to studies, clinical trials? Is it A. recombinant factor 7A 100 micrograms for 8 doses? Or B. octreotide 50 micrograms as an IV bolus followed by a 50 micrograms per hour infusion? Or C. pantoprazole 80 mg as an IV bolus followed by an 8 mg per hour infusion? Or is it D. a restrictive transfusion strategy with a threshold hemoglobin of 7 grams per deciliter? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. a restrictive transfusion strategy with a threshold hemoglobin of 7 grams per deciliter. A large randomized, controlled trial demonstrated reduced 45-day mortality when a restrictive transfusion strategy with a threshold hemoglobin of 7 mg per deciliter was used instead of a liberal transfusion strategy with a threshold hemoglobin of 9 mg per deciliter in patients with acute upper GI bleeding. There are no mortality data supporting the use of IV pantoprazole in patients with acute upper GI bleeding, although reduced recurrence of bleeding has been demonstrated in patients with ulcerative bleeding. There are no mortality data supporting the use of octreotide in patients with acute upper GI bleeding, although improved rates of hemostasis have been demonstrated. Several trials using recombinant factor 7A have failed to show benefit in patients with acute upper GI bleeding. Please proceed to the next question. And the next question reads, FKA is a 58-year-old male patient admitted to the trauma surgical ICU after a motor vehicle collision and multiple trauma. The surgical team noted a broken femur, radius fracture, and multiple facial lacerations. His leg was surgically repaired in the operation room and he is now intubated in the surgical ICU and experiencing extreme agitation. FKA's blood alcohol level on admission was 420 mg per deciliter, and he has a history of alcohol withdrawal seizures. So my question to you is, which of the following tools would be the most appropriate to monitor the course of FKA's alcohol withdrawal? Would it be A. Richmond Sedation Agitation Scale abbreviated as RASS? Or B. Confusion Assessment Method for the ICU abbreviated as CAM-ICU? Or C. Minnesota Detoxification Scale abbreviated as MINDS? Or would it be D. Clinical Institute Withdrawal Assessment for Alcohol revised abbreviated as CIWAAR? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Richmond Sedation Agitation Scale abbreviated as RASS. The CIWAAR has not been validated in a non-communicative ICU population. The MINDS scale has not been validated. The CAM-ICU is a tool used to identify delirium, but it would not be useful for identifying the other symptoms associated with alcohol withdrawal. The Richmond Agitation Sedation Scale abbreviated as RASS and Sedation Agitation Scale abbreviated as SAS are appropriate scales to use for non-verbal patients, e.g., FKA who is intubated, to monitor the severity of alcohol withdrawal in the ICU. These scales are the most widely utilized scales in the available ICU alcohol withdrawal literature. Thank you.